Okay, Mozam, what you have to present today?
Today,
Please.
sir, my patient name Ghulam Fareed, son of Bashir Ahmed, age 50 years, resident of Pakpatan and a laborer by profession, admitted via emergency 2 days back with complaint of lump in right lower abdomen for past 2 months and loose stools for the past 20 days. He was in his apparent state of health 2 months back when he noticed a small painless lump in the right lower abdomen, which was 3 into 3 centimeter in size as the approximate rate. It gradually increased in size over then and attained the current size of 13 to 13 centimeter. And
Gradually means for in how many days?
so in the past 2 months,
2 months.
it kept on increasing.
Okay.
It didn't reduce in size over the last 2 months, and it was a non-painful lump. And apart from that, along with that lump, patient started having lethargy and generalized weakness. And it was soft in consistency when patient first noticed it by himself, and it gradually became firm in consistency, what the patient says.
Okay.
And so patient gives history of 3 blood transfusions in the past 15 days.
So what I have understood up till now is that he is a 50 years old gentleman
Yes, sir.
and he developed a lump in right iliac
low-
fossa,
Right lower abdomen.
right iliac fossa, and then it was 2 months back.
2 months back.
It was soft in soft in consistency will be your finding.
So what the patient told me
Okay,
that initially
so-
it was soft and
All right,
now
okay.
it is firm in consistency.
All right. Okay.
And initially
Yeah, but it is better that these things should be examined instead of asking from the patient, because patient has his own definition of firmness and hardness, right? Okay, so there was a lump, and then it gradually increased in size,
Yes.
and it became hard.
and it was a painless lump. Patient has got no history of
Okay, so
associated
it's a
fever.
painless lump,
Yes, sir.
right? Okay, so what else would you like to know about that?
So patient gives a history of 3 blood transfusions in the past 15 days on every alternate day at Pakpatan,
Okay.
because he developed anemia also along with that lump, and he got his general checkup at some local doctor at Pakpatan.
In my opinion, the history is not yet completed, because if someone presents with such a lump, there are many more informations which are required before going to the treatment history.
Sir, apart from that, I ruled out the differentials, and
So that you have to describe. See, if someone has a lump in the right iliac fossa, it is for the 2 months, for the last, his patient is 50 years of age. That means what comes in your mind, just make a list and then keep on asking the question which will be either confirming it or ruling it out. By the way, what came in your mind when you had lump in right iliac fossa in 50 years old?
Sir, what the patient told, sir, I thought of that this might be some ileocecal mass, because it was
Okay,
painless
fine.
lump. Patient had gauze.
So what type of mass?
So can be some malignant growth,
Some malignant growth.
because
So-
patient gives history of weight loss.
Right.
In the
So when you were describing it, I haven't seen this patient. This is the first time I'm seeing it. So what came in my mind was carcinoma of the cecum, right?
Yes.
Right. The second possibility was
Can be, sir, ileocecal tuberculosis, which is
okay,
quite common.
ileocecal
and
tuberculosis.
But
Okay.
patient gives no history of any personal TB or any contact.
Okay. Anyways, tuberculosis. What else?
So carcinoid tumor, because appendix and ileum are
So
two common sites.
again a malignant thing.
Again.
So we are looking at something which is malignant related to gut.
Yes.
But your history has not described anything, any symptom related to gut.
Sir, I mentioned another presenting complaint of the patient. He was having loose
No,
stools.
before going into the point that he had blood transfusion and and all those things, first of all, each and every differential diagnosis has to be analyzed first in the terms of symptoms. If I would have been presenting it after telling the description of, the history of the lump, I would have said there is no history of bleeding per rectum. There is no history of melena. There is no history related to upper GI, right? So these are the things which were important. History of weight loss was important. Family history of any malignancy was important. History of previous operation was important, right? What type of medication was given, that is important.
That I all collected in the history of presenting complaint. I will-
Yeah, right. But in a long case presentation, you have to follow it in that systemic manner. Just remember that chart, which is patient's chart, which we have printed in this unit, and also just remember what is what we discuss in third year. The first thing is demeanor, then the presenting complaint, then the history of the particulars about the patient, presenting complaint, history of presenting complaint, then past history, then family history, then personal history, then review of the systems. Review of the system. Even if the problem is related to gastrointestinal tract, you have to hello, assalamu alaikum. Then you have to review the whole system and have to say some sentence which means there is no problem with the central nervous system, no problem with the respiratory system, all those things,
Yes.
right? Okay. So since we are just learning it, let's describe it again now.
Sir, my patient Ghulam Fareed, son of Bashir, 50 years of age, resident of Pakpatan, presented with a lump in the right lower abdomen for the past 2 months.
Okay.
And along with that, loose stools for the past 20 days.
Okay.
He was in his apparent state of health 2 months back when he noticed a painless 3 into 3 centimeter lump in the right lower abdomen.
Again in history, telling it 3 into 3 centimeter.
So
prop-
that you told you should correlate with the examination, your examination. So patient
At this stage, it is not important that 3 into 3. You know, when you just describe your examination, you can just tell it.
ठीक.
अभी तो आप history बता रहे हो ना?
notice a small lump.
There is a lump. Small or large is also a subjective sensation.
ठीक.
We are discussing it scientifically. There is nothing subjective that we should add. Patient has a huge swelling, is not a good sentence. Patient has a tiny swelling, is not correct, right? So there was a lump, that was enough, okay? Because what you are going to do is that you are creating an image about the diagnosis in examiner's mind, right? So there is a lump right side, most likely it is malignant in a male patient, although there is another differential diagnosis as well. For example, it can be an undescended testis and having a tumor in it, for example. It can be lymph nodes. It can be retroperitoneal tumor which is coming like that, right? So that is a possibility. But what are the most important working diagnoses? That those have to be analyzed,
And ruled out.
yeah, when you are describing the history. Okay.
So a lump in the right lower abdomen for the past 2 months.
Okay.
And loose stools for the past 20 days. He was in the apparent state of health 2 months back when he noticed a lump in the right iliac fossa. Lump gradually increased in size over the time. It was a painless lump and patient has got no associated fever with that lump.
All right.
And sir, patient gives history of lethargy and generalized weakness
Okay.
since then. And sir, apart from that, patient gives no history of any facial flushing, no personal history of TB, no family history of TB, and patient gives no significant urinary or bowel complaints except that loose stools, for which he took symptomatic treatment and he got relief from that.
All right.
So now for the past 15 days, patient underwent some basic investigations at Pakpatan and he was told that he is quite anemic, for which he underwent 3 blood transfusions on every alternate day. And so now he presented to us for further management and plan of that patient.
All right. So what are your findings on clinical evaluation?
Sir, there is a 13 into 14 centimeter lump palpable in the right iliac fossa. That lump is
Normally, what you do when you have a patient, do you directly jump to the pathology or?
so first I would have the general inspection of the
Yeah,
patient.
so there has to be, patient is hemodynamically stable, patient has no significant findings on general physical examination, or if there is a finding, you have to describe that finding and then you have to go for the local examination, right? Because just having a lump, you know, without a overall picture of patient's demeanor and well-being will be incomplete. So please remember that algorithm. That algorithm was, let me repeat it, demeanor of the patient, particulars about patient, history of presenting complaint, history of presenting complaint, past history, family history, personal history, medical treatment, right? Review of the system, right? Whole review of the system, right? If someone is coming with a hernia, then it is important to say that I could not find anything wrong in a systemic examination. Just at a postgraduate level, this sentence is enough, right? Or you can say there is nothing wrong with the chest, there is nothing wrong with the abdomen, blah, 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 all right? So, is there anything wrong in general physical examination?
So patient is lying comfortably, he is well oriented,
Okay.
but he has got a lethargic feeling and he has got obvious pallor and
So this is very
signs of
important.
anemia.
Someone has a lump for 2 months and has an obvious pallor. So that's the correlation. हाँ जी. Did you talk about melena in the history?
Yes, sir. I asked the patient.
No, what did you tell me?
Sir, I told you that he has got no urinary and bowel
Okay.
symptoms.
But there are certain symptoms which are important negative symptoms.
Negative.
Right? There are, what we're supposed to tell are the important positive symptoms and important negative symptoms. For example, if someone has got a lump in the right hypochondrium, it is important to tell that there is no jaundice. Although you don't tell nothing, which is, you don't describe nothingness, but this nothingness is important. Right? So in this patient, it was important. Bleeding per rectum was important. Change in bowel habit was important. Right? All right. Okay, carry on.
And so the patient has got a disability of.
So on general physical examination, he's pale. Apart from that, there is no other finding.
And there is a disability. He has got a previous amputation of his right hand due to Toka machine.
Okay.
That is previous history. Sir.
Okay, fine.
And sir, apart from that, general physical examination is unremarkable for any significant positive or negative. And sir, on the examination of the abdomen, there is no visible lump, but on palpation, there is a 13 into 14 centimeter lump in the mass in the right iliac fossa.
Okay.
And it is a non-tender mass, and overlying skin has got temperature comparable to the surrounding skin. And sir, it does not move with respiration, but it is a mobile lump, partially mobile lump, sir. And all the borders are well
What is partially mobile?
Sir, not freely mobile.
So anything which is doubtful should not be. Yeah, few things are not slight, right?
Yes or no?
You can't say she's slightly pregnant, right? Or he is slightly married. You can't say that, right? So there are. So anyway, so is this mobile or is it not mobile, right? Okay. One important thing is missed. What was the thing which is missed, Tanveer sir?
So all the borders are palpable except at the
Is it intra-abdominal or extra-abdominal?
So it was intra-abdominal. Carnage sign was negative.
So instead of coverage, that should be part of your description. So it's an intra-abdominal swelling. Okay. Is it bimanually palpable?
So it was not bimanually palpable.
But it should be described. Because if, for example, it's a kidney which is undescended, lower lying kidney, or any retroperitoneal mass, it should be bimanually palpable. So this completes the whole description.
And
Okay.
sir, apart from
Okay.
that,
What are the findings? What are the
sir,
findings?
apart from that, no scrotal pathology. Testes are in their normal position.
Yeah, this is important.
And patient has got no urinary complaints and no recent onset of diabetes mellitus.
Okay.
So to rule out any.
And any other viscera, liver, spleen?
So the rest of the abdominal,
Okay.
there is no visceromegaly, but patient has got shifting dullness positive.
Oh, so there is a free fluid in peritoneal cavity.
Yes.
Right. So there is a free fluid in peritoneal cavity, and patient has got a lump. Okay. Anything? Supraclavicular lymph nodes?
No, sir. No.
But do we have any importance of it?
Yes, sir. Any intra-abdominal pathology should have.
What is the name of that lymph node?
Virtuous lymph node.
So
Left
what is the correlation?
Because the lymphatic drainage of the abdomen is at the junction of the left subclavian and internal jugular vein, and if there is retrograde flow, so we can have the lymph node palpable. Which is
But what are the common tumors in which this is palpable?
subpancreatic, stomach malignancy,
Fine.
and
Fine. Okay. So you don't find anything else
no, sir.
important?
Okay.
Okay.
Examination is unremarkable.
Okay.
Patient gives, patient complains of slight pain in the left lower limb that is radiating down to the dorsal aspect of the thigh and calf, but patient has got a normal extension.
Now let me give you a little tip for the exam. I mean, for practical, when you're examining, when you are treating the patient, obviously you will give heed to every point. But this is such a small point, maybe related to some osteoarthritic spine or some other thing. So don't mention it in this long case. Maybe in a past, maybe in a past history or maybe associated symptoms, you just we have to be honest about it. But just don't distract the examiner by just telling something. For example, if he has got an ingrowing toenail and you focus on ingrowing toenail, it is there, but when you are appearing in an exam and you have to be evaluated in half an hour, then just guide the examiner, right? If you are an intelligent student, you actually put the question in examiner's mouth yourself, right? If your description is not generating a diagnosis in examiner's mind, that means you are doing something wrong. And if your examiner is interrupting you in between, that means there is something wrong. So this is just a yardstick, right? If everything, please remember that sheet, which I have just described 4 or 5 times now. Follow that pattern. Okay, now this is abdominal examination. Anything else in the examination related to lump?
So PR examination was unremarkable for any.
Fine, and that was an important
Yes.
thing. All right, okay. Did you examine the back of the patient?
Yes, I examined.
Did you find any
No,
significant
so there was no
thing?
sacral edema. There was no lumbar hernia.
Fine, right. So any chest, finding a chest examination? Or
No, sir. Patient,
So on
he
the
is
basis,
a known hookah smoker for the past 15 years, but there were no added sounds.
but that that should have come earlier. In particulars about patient, the 50 years old gentleman who is a laborer working flana and is a smoker and with a previous history of an injury where there was an auto amputation of the, all these things, picture of the patient should have come before actually presenting complaint. समझ में आई बात? Okay, on the basis of this, now what is your working diagnosis?
So this is most probably a case of cecal growth,
All right, fine.
because patient gives history of significant weight loss,
Okay.
and that mass kept on increasing in size. It was a painless lump. Patient gives no history of associated fever,
Say.
and apart from that, sir, patient gives history of 3 blood transfusions, which is significant.
How a patient of carcinoma of cecum can present apart from this lump? Is there any other presentation as well?
So patient can present with alteration in bowel habits, and apart from that, patient can also present with melena.
Melena? Why melena?
So because there can be ingoing
Blood loss?
intraluminal blood loss, and that can present.
So why blood becomes black?
So because the hemoglobin is broken down,
And?
it has to pass through a long course of the GI tract, and that converts into hemosiderin and that
Acid hematin.
acid hematin.
But where is the acid? In the cecum there is no acid. Blood comes in contact with the acid, becomes acid hematin and becomes black.
Black.
So if bleeding is in upper GI, then it is melena. So there will be hematochezia instead of melena, son. Why blood will be black? Blood will not be black, right? आपको समझ में आई बात? Okay, what are the presentations?
So apart from that, patient can have a abdominal pain,
Okay,
and so
and can be diagnosed as
it's a dull
acute appendicitis.
appendicitis.
So anyone above in this age group, if comes with acute appendicitis, think of CSC.
CS.
And one more very important presentation which was there in this patient as well, and that may be the first presentation. Pallor.
Pallor.
Anemia may be the first presentation of carcinoma of the cecum. So these are various presentations, right? Okay, fine. Okay, now how will we proceed forward?
So first, I will have the baseline investigation of this patient, because patient is presently having pallor. So I would address his hemoglobin, and if he needs blood transfusion, then I will arrange for the blood transfusion. And sir, apart from that, I would going to have some investigations to diagnose the pathology. For that, sir, I would prepare the patient for colonoscopy.
Okay.
And
Okay, colonoscopy shows there is a mass present in the cecum, fungating mass, and the biopsy shows adenocarcinoma. What would you do now?
So then I will get the staging workup of the patient, and
Okay.
that includes the CT chest, abdomen, and pelvis.
So let me interrupt you. If a question is asked from you, what is the treatment of carcinoma of esophagus, or carcinoma of the bronchus, or carcinoma of malignancy of testes, or CA breast, the answer is not mastectomy or lobectomy or thyroidectomy. The answer is treatment depends upon
Stage of the disease.
right. Please remember, this is a very important thing. So you will do staging.
Yes.
So okay.
So staging workup includes the CT chest, abdomen, and pelvis of the patient.
No, you don't do a clinical staging first.
Yes, the clinical staging.
So you already said there is ascites.
Yes.
So probably it is stage 4 already.
Yes.
So you got to do some
First,
some
detailed
evidence.
clinical examination.
Maybe ascitic fluid tap
Yes.
and see if there are malignant cells there. It is already stage 4. All right. Okay. And what else?
And sir, apart from that, all the basic investigations and the serum CEA levels. As a
CA
tumor
levels. Okay.
marker.
Okay. CEA level is not enlarged, not increased, and there is ascites. Liver is normal. There is no abdominal lymphadenopathy apart from few lymph nodes around the cecum. How will you proceed forward?
So that makes it a locally advanced cecal CA, and the patient is a potential candidate for
Why locally advanced?
So because localized lymph nodes are enlarged, and that
So
makes
is it
stage
advanced?
3. That makes it stage 3, sir.
All right.
Stage 1 and 2 has got no lymph node involvement. The tumor is limited to the cecal wall, and stage 3 has got lymph node involvement. And
All right. Okay. So will it be called advanced or?
locally invasive.
For me as a surgeon, the question is it doable or it is not doable?
Resectable or not?
So it is a doable as per the scenario.
It's a doable or it's not doable. Only issue is ascites. In that case, we can have ascitic tap. Moreover, in case of carcinoma of cecum, with this situation, even if we decided that it is not curative, then even then for palliation also we require surgery. And we will take ascitic fluid and obviously if you are doing it laparoscopically, then also you can take a peritoneal biopsy, and if you do it in open, so you can take ascitic fluid for cytology, and you can also take a peritoneal biopsy, right? So you will open it. Which you like, laparoscopic or
So
open?
for so if the expertise are available.
No,
then-
about you. You are treating it.
So I will treat it open.
All right. So you open it, and what procedure you will plan?
So as this patient is having cecal growth, so I will plan for standard right hemicolectomy.
All right. What do you mean by standard?
So standard right hemicolectomy is resecting the terminal 10 to 20 centimeter of the ileum, along with that cecum, whole ascending colon, hepatic flexure, and proximal 1/3 of the transverse colon.
Okay. So it is based on what?
So based upon the blood.
It is just on the measuring that 20 centimeter ransom, or based on what?
So based upon the blood
Okay.
supply.
So you ligate the
Ileocholic
feeding.
artery,
Ileocholic artery.
right colic artery, and right branch of the middle colon.
Very nice. Very nice. So you will just do that and remove whole as a bulk,
Specimen
and we'll
and
take it out.
Will have the primary anastomosis of
Okay.
the rest of the gut.
So the biopsy comes as adenocarcinoma, lymph nodes. You have removed, say, 20 lymph nodes, and out of them 4 had metastases, and incidentally your ascitic fluid does not have malignant cells, and the peritoneal biopsy taken from different places does not show any malignant cell. What next?
Sir, as you've mentioned that there are 4 positive lymph nodes, so 4 positive lymph nodes indicates a poor prognostic factor, and sir, then this case should be further discussed with the oncologist, and if he agrees to give the adjuvant chemotherapy to the patient, then that should be planned.
Okay. All right. And what will be your follow-up plan?
So follow plan, patient should have 3 to 6 monthly clinical examination, and sir, apart from that, ultrasound abdomen and serum CEA levels for the follow up.
Okay, but CA level was already negative.
So but it helps in the follow up of the patient if the level.
No, but if it was not there to start with when there was a disease inside, how do we expect it to rise?
Sir,
What we label a patient has a colorectal malignancy, but CE level is not high. What we label this patient? इसको क्या कहते हैं ऐसे patient? We call them non-secretors. So 70% of them have CEA level, but rest of them are maybe non-secretors. In that case, there are other tumor markers you can just order, like alpha fetoprotein.
for that cecal.
Yes, for those who are non-secretors, because in few cases that may be used as an follow-up indicator.
Follow-up.
And if they are non-secretors, then they are non-secretors. Okay, then you will follow up. All right, okay. Thank you. So, I mean, what I suggest is that,
Sir, colonoscopy should be included in the follow-up also.
yeah, I mean, if CEA level ho, phir to it is better to do it CA level. Otherwise, check colonoscopies can be done, and then CT scans, of course. Usually, the follow-up plan is that you follow with the CEA level. If CEA level is high, then you do abdo-CT with oral and IV contrast. देखें, बाकी is all right. There's no deficiency of knowledge, but organize करें इसको भी और ज़हन में और गैर ज़रूरी चीज़ों पे इधर-उधर ना निकलें. पहले आप history, complete your history first, then complete your clinical examination, then complete your clinical examination, and then you do all the documents. Good luck. When is your exam?
27, 28.
Good luck.
Thank you, sir. Thank you.